for many years is that your insurance, your health insurance, is tied to your job. And when people lose their job, they tend to lose their health insurance. So periods of recession, you tend to see, it's a little bit different here in Utah, but there was definitely a recession in the mid-2000s. You tend to see the number of uninsured go way, way up. And what the Affordable Care Act is trying to do is actually create a whole new option for people to get insurance that isn't linked to their job, so that we don't have this constant up and down of people being insured and uninsured that's tied to the economy. And hopefully, we'll bring that number, 13.2, down in Utah, just as Massachusetts was able to do by implementing the same reforms. Now, will it happen in all states like it happened in Massachusetts? Probably not. We've got 50 experiments going on right now, and probably not all of them are going to work. But certainly in Utah, we want to make it work here, including that people who don't like the Affordable Care Act realize, hey, we're on this train, we've got to ride it, we've got to make sure that it can happen. So this is sort of where we're starting out from, 13.2% unemployment. And I'm hoping that as I do these presentations over the next couple of years, I'll be able to add some new bar charts that show that that number is coming down, that we are actually putting a dent into the number of uninsured. Because the uninsured are actually a pretty significant drain on our healthcare system. Because we do provide them with care, but we do it in a pretty spotty and a pretty episodic way that isn't really the best care, as you are probably learning about how to deliver. First of all, the uninsured go to emergency rooms. That is their primary care doctor. Everything from an earache to a broken arm to diabetes shock. They're going to the emergency room because that's where the place they know they can't be turned away. They're going to ad hoc clinics where they take something like a basketball stadium, fill it up with 100 dentists and just do round-the-clock root canals. And that works. People get care for free that they're not getting anywhere else. But what happens when that root canal gets infected a week later? They go back to the basketball stadium, there's going to be some basketball games going on there. There's not going to be 100 dentists anymore. So they've got to go to the emergency room. So again, it's not that consistent care that you get from a primary care setting. People go to federally funded clinics, the FQHC system, which we'll talk about in a little bit. Those are clinics that do welcome everybody to come through their door, pay on a sliding scale, whether you're insured or uninsured. You guys have a great system in Ogden called the Midtown Community Health Clinics that deliver excellent care. And my wife was a family doctor at one of these clinics down in Salt Lake. So they're there as a safety net as well. They provide really good care, evidence-based medicine, but they're overwhelmed. They have a lot of people using their services. And then, of course, people wait. They wait until something like a cold becomes pneumonia. They wait until diabetic shock becomes something that needs to be amputated. And that raises the cost of the care that eventually needs to be delivered to them. As you know, the earlier you treat something, the more preventative care you deliver, the cheaper it is, not only for the patient, but for the system overall. And actually treating these uninsured folks has a cost. It adds about $1,000 to the insurance premium of an average family in the United States, about $300 to the average individual. So we're paying, if you have insurance, you're paying for treating the uninsured, but you just don't realize it, because it's baked into the cost of your premiums that you pay to your insurance company, because they're absorbing all of these costs that aren't being reimbursed. After the Affordable Care Act, let's figure out where we might be going on this. And as I mentioned, it might work in all states. Probably not going to. It's going to work in some states. It's probably not going to work in other states. We're really in an experimental phase. And what I'd like to say is that if you're going into healthcare right now, it's kind of like you're joining NASA in 1965. Back in 1965, they knew they were going to the moon. They didn't know if they'd get there, and they certainly didn't know if they'd get those astronauts back. But that's what they were working on. And with health reform, you're trying to go to the moon. The Affordable Care Act has some ambitious goals and some ambitious ideas. And if you're joining this field right now, you're joining NASA in 1965. Now, you're not wearing the skinny ties and the buzz cuts and things like that, which is good because that fashion sense is way out. But you are embarking on an interesting career in a very, very interesting time. So let's see what's going to happen. As I mentioned, the Affordable Care Act isn't going to address all those cost issues that I talked about. That's right here. You remember how an appendectomy costs 3 times as much in the United States as it does in Germany? That's this pillar of healthcare reform. Affordable Care Act kind of touches it a little bit, but it's not the main focus. What the Affordable Care Act does is it focuses on expanding coverage. That's its main goal right now. And the analogy I use is that we're trying to put everybody in the boat before we figure out how low it rides in the water and how far we can go with it. Because if you start plotting where you're going to go with a boat before you add everybody into it and sort of know the logistics of that, then you're probably going to run into trouble. So we're getting everybody into the boat first. We're trying to expand coverage to figure out what is our, what it can sustain. And that's really what it does. Ensuring quality and containing costs are going to come down the road, and that's actually what Massachusetts is doing, because they're ahead of everyone else right now. They're dealing with those issues, but the rest of us are just trying to expand coverage. Now, and also the other thing about the Affordable Care Act is that it has actually been in operation for a couple of years. I mean, we all know about October 1st, the horrible website, people trying to sign up, but there are things that you have probably actually experienced even, or know about, that are actually related to the Affordable Care Act. Adults under age 26 can stay on their parents' insurance plan. There's 26,000 Utahns and 7 million young adults across the country who have had that option now available to them. A lot of people we talk to in universities are very familiar with that. No more lifetime caps on insurance payments. Used to be you'd reach about a $2 million or $1 million cap, and then the insurance company could say, we're not going to pay anymore. And those parents or individuals would go into bankruptcy or get on Medicaid or something like that. No longer can there be a cap on insurance benefits or payouts. That's a big boon to people who have chronic diseases like kids with leukemia, who usually would hit those caps even in their teens. Men and women paying the same for coverage. That starts on January 1st. Right now, women pay more for their insurance coverage, sometimes a lot more. And that's nothing related to their health history. It's just that they're a woman. And potentially, I guess, they could become pregnant. Going forward, any insurance you buy after January 1st, men and women pay the same. Now, I can't say men and women are going to pay the same for haircuts. I've read the Affordable Care Act. There's nothing in the law about that. But at least when you go and shop for insurance after January 1st, it'll say a 27-year-old resident of Weber County will pay this. It won't say a man will pay this and a woman will pay that. It's going to be the same. And then lastly, no one can be denied or priced out of coverage for a pre-existing condition. And what does that mean? That means that maybe when you were 16, you got mono. And so when you go and you sign up for health insurance, you've got to write down that you had mono. Or maybe you've got a bad back because of a motorcycle accident. Or you have diabetes. Or even I had a friend who had some voice issues because she was a singer, and so she had to get some voice treatment. Well, when you sign up for health insurance today, and for many years in the past, you would have to list all of the sort of health issues that you had, your medications, things that were wrong with you. And then the insurance company would take a look at that and decide, well, should we provide them with insurance or not? And they could deny you or they could accept you, and then they could raise your premium based on how sick you are and how much of a risk they thought you could be. So if you have a lot of health issues, they would really jack up the price. If you were young and healthy, they would keep the price pretty low. And so people would be paying incredibly different premiums for the same kind of insurance based on their health history. For kids, right now, insurance companies can't do that anymore. Since 2010, your health history doesn't matter. And starting on January 1st, for adults, that kicks in. So for my 60-year-old nanny, when she went and applied for health insurance earlier this year, she was quoted $950 because of her health issues. When she buys insurance after January 1st, with the premium subsidy she's going to get, her monthly premium is going to be about $260. Because that health history that was causing her rates to go way up is no longer an issue. The fact that she's a woman is no longer an issue. There's a lot of things that are going to make her rates more affordable. This is one of the huge game changers with the Affordable Care Act. And one of the things we're actually reading about in the news now about whether people are trying to continue their canceled coverage versus buying new coverage that's going to start on January 1st. Because one of the big differences is all of that canceled coverage that you hear about does have exclusions based on pre-existing conditions. They can charge you more based on your health history. Any new coverage you buy after January 1st can't do that. So there's some, the fine print is very important to read if you find yourself in that situation. Because this is something that's going to lower the bills for quite a few people, including my nanny. And then a lot more preventative care. Flu shots, blood pressure checks, well child checks. All of these are provided without co-pays or deductibles now, and that started about a year and a half ago. One thing to keep in mind, though, is if you go in for preventative care and they find something, all of a sudden, you got a fever or something like that, all of a sudden that ceases to be a preventative care visit and becomes a sick visit, so you will get a copay. You will get something you will have to pay. But if it's strictly preventative care, then you won't get that extra charge because that's one of the innovations the Affordable Care Act has, is that preventative care actually pays dividends to the system and keeps people healthier. So these things have been going on. for the past couple of years. And they are a part of the Affordable Care Act, even though a lot of people don't realize it. And even if the website is down and broken and things like that, which we all know it is, these are still going on. These are still in existence and still helping many people out right now. Yeah. Now, if we were to jump up to 30,000 feet and look down at America under the Affordable Care Act, and we happen to be looking at a PowerPoint slide, this is kind of what it would look like. What I've done is I've tried to show how the Affordable Care Act influences different types of people. And what you'll notice is that for the three categories at the top, there's not a whole lot of changes that happen to them. People who work for companies and get employer-based insurance, either big, like Wells Fargo, or small, like the group I work for, or senior citizens on Medicare, or people on Medicaid, people on TRICARE, the veterans benefits or military insurance. There's not that many changes there because the Affordable Care Act isn't focused on changing anything with them. It's really focused on the people who have struggled with getting insurance, affording insurance, or just haven't been insured at all through personal choice. So 85% of the country, they're going to have some changes. Yeah, you know, there's going to be the 10 essential health benefits that now small group insurance is going to have to cover. Senior citizens on Medicare, their prescription drug donut hole is going to go away. That's going to save them about $1,000 to $1,500 a year by the year 2020. If you work for a big company like Wells Fargo, Affordable Care Act can't touch you. You're outside of what's known as the ERISA market. And so there's nothing that happens with your insurance. You could offer insurance or not offer insurance. Well, I guess you have to offer some kind of insurance if you're over 50 employees. But there's nothing that changes with the benefits that you have to offer because you're completely outside of it. So a lot of people think the Affordable Care Act is going to come in and change everything about how they do things. But it's really this 15 to 20% down here that the real changes are happening. Everybody up at the top, and generally the people who have employer-based insurance or on government programs right now, not a whole lot of changes are happening to them. The folks that are getting their cancel policies right now in the mail, they're down here. It's actually about 5 to 10% of Americans that are that get private health insurance. And so they're actually in this category right here. It's not the folks who are up in the employer-based insurance part. And these people down at the bottom who have lost their job or looking for insurance or working for businesses that don't provide insurance, there's a couple of innovations that are going to try to help them make this insurance not only easier to buy, but more affordable and easier to keep as well. Because if they lose their job, from now on they're not going to lose their insurance if they're buying it through the new marketplace. So let's jump ahead. We'll go to a little bit of policy basics. I'm not going to spend too much time on this. The Affordable Care Act asks every state to set up 2 marketplaces in their state. Think about it. 2 senators in each state, 2 marketplaces in each state. One is going to be for individuals and families, for ordinary every people to go and buy insurance, and the other is going to be for small businesses, where a small business owner can take their employees to this marketplace to buy insurance. So every state gets these: Connecticut, California, New Jersey, and Utah. Every state's going to have these 2 marketplaces. It's really modeled after what Massachusetts did 7 or 8 years ago. You can jump to the next one. So Utah had a choice about how to approach this. It wasn't that the government said, you've got to set up your marketplaces this way. There's a bit of federalism involved. They said you can actually choose how you want to approach it. So we could have been like Texas, which said, you know, Obamacare, not really our thing. You know, we don't really want to touch it. So ironically, basically they let the federal government run everything in their state, all the marketplaces in their state. Or we could have been like California, which is, hey, we love Obamacare. We want to do it. And so the state of California is actually running the marketplaces in their state. They call it Covered California. They have advertisements with palm trees and sandy beaches and, you know, really good-looking celebrities talking all about health insurance. So they're doing their own thing right there in California. They're taking control of it. Or we could have been like Arkansas. And we could have said, you know, we're going to go half and half with the federal government. We're going to run some parts of this health reform, this Obamacare. We're going to ask you to run some parts of it. We're going to work together in a partnership or a hybrid exchange. Well, Utah looked at all 3 of these options. For a while, we thought we'd actually run the state-run exchange. That was what Governor Herbert wanted to do. And then we kind of veered towards the federal exchange, and then we even kind of dated a little bit with the partnership exchange. But being Utah, what we decided to do was we said, you know, these are 3 options, but they don't really work for us. We're going to make a 4th option. We're going to walk right through it. And that's what Utah did, is we created what's known as the split model, where the federal government is going to run the individuals and families marketplace, healthcare.gov, and the state is going to continue running the small business marketplace in the state. So it was unique. No other state had proposed this. Governor Herbert negotiated with the federal government and got it approved last May. And this is what we're operating in right now. We're sort of the 4th way to approach the Affordable Care Act. We heard Mississippi is interested in following us, so this could become a new option that other states pursue. Now in Utah, we've already had a small business marketplace going back to about 2010, because as Carla mentioned, Utah had sort of gotten a little bit onto the health reform bandwagon earlier under Governor Huntsman and Governor Levitt. And so we had a small business marketplace that predated Obamacare. And that's one reason why Utah did this model, is because they wanted to preserve that. They wanted to preserve what's known as Avenue H. And I actually, just driving up here, saw some billboards for Avenue H along I-15. So they're doing some advertising now, trying to bring people and small business owners into the marketplace to get their insurance there. But here's how it works. If you're an average Joe, and I used to be a freelance writer, so I used to buy my own insurance in the private market, I can't go to Avenue H. I can only go to Avenue H if I have between 2 and 50 employees in my business right now. If I'm an average Joe, I go to the individual and families marketplace. That's where I go and get my insurance. If I work for a company that doesn't provide insurance, or I'm self-employed, or I'm unemployed and uninsured, I go to the individuals and families marketplace. The only way you can go to Avenue H is if you work for a small business, under 50 employees, and your boss takes you there. And even if they take you there, you can still bail out and go to the individuals and families marketplace if you decide. So based on those constraints, we think a couple 100,000 people in Utah are going to get their insurance on the individuals and families marketplace, and a couple thousand, maybe 10,000 at the high end, will get their insurance on Avenue H. It kind of depends on how popular, how much advertising they do, and things like that. But at the Utah Health Policy Project, we tend to focus on the individuals and families marketplace. That's who we are talking about, because the state is really doing its own promotion around Avenue H. Jump to the next one. If we were to look at a national map about how this all works out, the dark states are the states that are running their own state exchanges, like California or Oregon. Up in Minnesota, they're using ads with Paul Bunyan, falling off roofs and falling into frozen lakes and things like that to kind of get the point across that health insurance is a good idea. So these dark blue states are the ones that are doing it themselves. The really light blue states are the ones letting the federal government run everything there. The middle blue states are those hybrid exchanges like Arkansas, where they're kind of going half and half. And then Utah, which is probably the only national map where we'll be purple on for quite a long time, is doing its own thing. We're doing this split model where the feds are running half of it and the state is running the other half. When they set up the Affordable Care Act back in 2010, I think they thought there'd be a lot more dark blue states on this map. They thought more states would want to take control and do it themselves. And so they were very surprised when it worked out that you have 26 federal exchanges, or 26 states where the feds are running everything, which is one reason why healthcare.gov was such a disaster when that website launched, because it's not just one website. You go to healthcare.gov and then you immediately choose what state you're in. So it's not just one website, it's 26 websites, and in fact it's 42 websites because there's a small business side of that as well. So they really had to set up quite a few dynamic websites for many more states than I think they intended to. Not to give them any excuses for really bombing that rollout, but they did have a lot more work than they intended to do. And here in Utah, we are using healthcare.gov. Because this is the website where folks are going through and finding their insurance. This is a screen capture just from a couple days ago. You guys remember the young woman who used to be on the website? You probably read stories about her. She just actually did an interview on ABC News because she was really upset about the bullying she was getting. Well, now they've changed it. They don't have that young woman there. They just have ways to help get you insured. But if you want insurance in Utah, and you want to go through the marketplace for individuals and families, you go to healthcare.gov. That is the only portal that you can access that for. And it's kind of important because if you want to see if you qualify for subsidies to make your insurance more affordable, this is the only place you can go. If you go to the private market, call up an insurance company and get insurance that way, you can definitely get insurance. But you could be leaving a couple $100s a month on the table by doing that if you were to qualify for subsidies. So it's a really good idea to go through healthcare.gov to find out if you're going to get that help every month to pay for insurance, because there's a lot you can do with an extra $300 a month. It could definitely help. So the website's healthcare.gov. It's also available in Spanish, and there's the toll-free number 1-800-318-2596. Now we've heard the website is bad, and it certainly was bad. We can jump to the next one, but it is getting better. These are some screenshots from earlier this week where we were enrolling. Actually was fake enrolling myself. You can go in there, you can use it. Some of the tricks that we've used, if you've had trouble logging in, delete your internet cache or your internet cookies, or just download a new browser. If you're using Internet Explorer, download Chrome or download a fresh version of Firefox and just use that, because there's a lot of bad logins previously which have been clogging up the pipes. They say the website's going to be fixed by the end of this month. Unfortunately, I don't think that's going to be true. I think it's going to be sometime in early December, mid-December when it's going to be fixed, which really runs really close to that December 15th deadline of when you need to sign up for insurance that starts January 1st. So that's really causing some anxiety for advocates and organizers like myself that we want people to have that insurance that starts January 1st, and it's going to be pretty tight. The good news is it takes about 45 minutes to sign up. So it's not an extremely lengthy process. Because again, you don't need to fill out your health history anymore. It's a totally different kind of insurance application process. Jump to the next. Now on the Utah marketplace, we've actually got a pretty good deal going on. We have 6 major insurers offering insurance, offering 96 plans. And these are the big insurers. These are the billboards you see driving up and down I-15 or 89 that are offering the insurance. I mean, Select Health and Altius sort of are the 2 bigger plans, and we got a lot of other ones as well. There's also a bunch of dental plans. If you're in a smaller state like Wyoming or Georgia or Mississippi or Alabama, they actually have many fewer insurers and many fewer plans, which has really reduced the amount of competition they have. So Utah's pretty lucky that we've got this robust of a marketplace going for us, because what it means is that more competition is bringing down the prices, and we've got some of the lowest prices, lowest premium prices in the country. Yep. So what is the marketplace going to be like? Well, before we get into the guts, let me just step back anecdotally. Shopping for insurance on the Utah marketplace is going to be a lot like buying breakfast cereal. And you might be like, whoa, how's that possible? How could it be that shopping for something as complicated as insurance can be as easy as going buying your Fruit Loops, at your local supermarket? And here's why. Supermarkets are smart. They put all the breakfast cereals in one aisle. So that when you go to the supermarket and you want your breakfast cereals, you go to aisle 3 and you have all the choices lined up in front of you. And you can take the boxes, hold them next to each other, look at the nutrition facts. You've got a 2-year-old like me, they shake it to see if there's a toy inside. All of your choices are right there. And not only that, but the prices are right there on the boxes as well. So you know exactly what you're going to be paying when you go and you check out from the supermarket. The insurance market up until now has been very different. You basically have to go to one insurance website, fill out a long health history survey, and then get a quote. And that quote would be based on how sick you were or your age and smoking history and things like that. If you wanted another quote, you'd have to go to a completely different company and fill out an entirely new survey and get a different quote that way, and then go to another one and get a whole different quote. And that could take hours and hours to actually build the same competitive advantage that you gain by going to the supermarket cereal aisle, where you have all of the prices and all the products right in front of you with no gimmicks, and it's all pretty transparent. What the marketplace does is it takes insurance plans and insurance providers and puts them in one spot, in one cereal aisle, so that the numbers that you're seeing and the information you're seeing about these insurance policies are all consistent and they're all in front of you, so that you can hold up one insurance policy, see the deductible, see the premium, see the provider network, see what it covers, and then hold up another right next to it and see those exact same details, just like you're comparing boxes of cereal. And then imagine this. If you were going to a cereal aisle and you had a box of Cheerios and it said $2 on the box, and then you bring it to the checkout line and they scan it and it says, oh, it's not $2, it's $10. Well, that would be kind of a shock, wouldn't it? And that's one of the challenges with the private insurance market right now, is there's a $2 prices for everybody, but once you fill out that health survey, you could be paying $10 depending on what kind of health status you have. So there wasn't that same transparency about knowing exactly what you were going to pay and everyone paying sort of a similar price for it. So what the marketplace does is it has the prices right there as well, and there's no shock that you find out when you go to the checkout line to actually purchase it. The price you see is the price you're going to pay, and if anything, it's going to be lower based on the premium subsidies that you could get. So that's, I'm sorry, can you go back once more? So that's why the supermarket checkout line is very similar. Supermarket cereal line or aisle is very similar to what shopping for insurance is like. But there is one caveat.